Hello and welcome to the video. Today I'm going to be talking about an approach to investigating arthralgia or joint pain with a focus on how to evaluate for underlying autoimmune disease etiologies. So without further ado, let's get right into it. Arthralgia is a relatively common presenting complaint that clinicians encounter, and there are several etiologies that can cause joint pain. Firstly, joint pain can be mechanical in nature, where mechanical forces on the joint leads to injury and pain. This can happen acutely with relatively high force trauma, or the mechanical damage can occur slowly and accumulate over time through mechanical stress on joints, particularly weight-bearing joints, and joints that are frequently used through activities of daily living and occupation. Joint pain of this nature is known as osteoarthritis, and therefore commonly occurs in high-stress weight-bearing joints like the hips, knees, and spine, as well as the small joints of the hands and wrist. The mechanical damage over time can lead to cartilage destruction and therefore joint space narrowing, which is often asymmetrical and worse medially in the large joints like the knees and hips. There can also be reactive bone formation known as osteophytes, which are commonly picked up on X-rays surrounding the diseased joint, as well as the features of subchondral sclerosis and possibly subchondral cysts as well. There can also be bony enlargement of the proximal and distal interphalangeal joint, known as Bouchard's and Heberdin's nodes respectively, which are readily detected on clinical examination. Treatment of arthritis of a mechanical nature involves simple analgesia, physiotherapy to strengthen the surrounding muscles, and reduction of the mechanical forces on the joint, which include things like weight loss, better ergonomics, and reducing repetitive stress motions, if these are contributing to the damage. If the joint space narrowing is severe and the symptoms are very debilitating, then orthopedic surgery may be required. Erosive osteoarthritis is a severe form of osteoarthritis thought to have an inflammatory component, and involves all the same types of treatment as osteoarthritis, but also including anti-inflammatory medications such as non-steroidal anti-inflammatory drugs, as well as possibly corticosteroid injections. Clinically, you would suspect that the cause of the joint pain is mechanical or osteoarthritis if there is a history of trauma or aggravation on a background of chronic osteoarthritis affecting the large weight-bearing joints or the small joints with typical findings on hand examination. Secondly, arthralgia may be secondary to a primary infection of the joint known as septic arthritis, and this is an important differential diagnosis to always consider when a patient presents with joint pain. Typically, septic arthritis is a monoarthritis where it affects a single joint, typically a large joint like a knee, hip, or shoulder. Because there's a developing bacterial infection within the joint can display all the cardinal signs of inflammation, including rubor or redness around the joint, calor or being hot to touch, dolor or being very painful, tumor or having significant edema or swelling around the joint, and functiolacia or a loss of function of the joint. The source of infection can either be from a surrounding cellulitis which tracks down into the joint, or seeding in the joint from a bacteremia, or introduction of bacteria into the joint through a procedure such as an injection or even through surgery. While septic arthritis can be a clinical diagnosis, it is best practice to always try and get a joint aspirate, as this may reveal the causative organism of the septic arthritis and help better direct antibiotic therapy. The joint aspirate is also very useful in helping distinguish septic arthritis from a crystal arthropathy, where the crystals can be visualized in the joint aspirate. Septic arthritis is treated with antibiotics for 2 to 6 weeks, and sometimes even more prolonged courses, depending on the type of infection and whether there is underlying metal wear, which may require revision surgery. If it is a native joint that is infected, a washout procedure done by orthopedic surgery is often required to gain source control. In contrast to the primary joint infection causing arthralgia in septic arthritis, other infections can also cause arthralgia as part of the immune response, particularly in viral infections such as influenza and more recently COVID. You can get a systemic inflammatory response, which can lead to symptoms such as arthralgia and myalgia. These symptoms resolve along with resolution of the inflammatory response as the patient recovers from the viral infection. You can also get an autoimmune mediated arthralgia that is triggered by a preceding infection in the case of rheumatic fever, where a preceding group A strep or Streptococcus pyogenes infection, typically causing a pharyngitis or colloquially known as strep throat, leads to an immune response that causes a migratory polyarthritis and potentially damage heart valves due to molecular mimicry between myosin and streptococcal antigens. We will discuss rheumatic fever a bit more later when we discuss the autoimmune and autoinflammatory diseases. The third cause of arthralgia is known as a crystal arthropathy, of which the two main types are that of gout, where the offending agent is monosodium urate crystals, or pseudogout, also known as calcium pyrophosphate deposition disease, where the calcium pyrophosphate crystals are the offending agent. Crystal arthropathies can present in a very similar fashion to septic arthritis, as both entities have similar affected joint distribution and can present with fevers and elevated inflammatory markers. The urate crystals in gout can precipitate in joints when there's a rapid change in the concentration of urate, on the background of having an elevated urate level. The precipitated crystals induces an inflammatory response and can therefore lead to the same cardinal signs of inflammation in the affected joints. Because precipitation tends to be temperature dependent, the peripheral joints, particularly the big toe or the first metatarsal phalangeal joint, is most commonly affected. The pain is often rapid in onset and very severe, and the joint becomes very exquisitely tender to touch. This is in contrast to septic arthritis, which tends to affect the larger joints, although gout can also occur in large joints such as the knee. The pain in septic arthritis is usually also not as acute as that of gout. As mentioned, joint aspiration is often the most useful intervention, as it can help with diagnosis by visualizing the monosodium urate crystals and assess for the presence of septic arthritis as the main differential by looking at the gram stain to see the presence of bacteria, and assess the white cell count, where a very elevated white cell count of more than 50,000 cells per high power field is more suggestive of a septic arthritis, although gout and inflammatory arthritis can also lead to high white cell counts close to that range. Sometimes the pain is often coming from stretching of the joint capsule due to the joint effusion from the inflammatory process, and so joint aspiration can also be therapeutic by relieving the pressure within the joint. In patients with recurrent, severe, and poorly controlled gout, the urate crystals deposited in the joints can build up to a point where they form gouty tophi, which erodes through the joint and can present as large mass-like structures surrounding the joint just under the skin. These are readily noted on clinical examination and can point you towards the diagnosis of gout. Patients with gout often also have underlying metabolic syndrome, including things like type 2 diabetes and obesity. Gout is ultimately an inflammatory response to the urate crystals, and so anti-inflammatory medications are used to treat gout, such as non-steroidal anti-inflammatory drugs and corticosteroids. However, more specifically, gout is thought to involve the inflammasome pathway, and so targeting this with a medication known as colchicine, a microtubule inhibitor which prevents the formation of the inflammasome and hence prevents the formation of pro-inflammatory cytokines at the start of the pathway, can be a very effective treatment for gout. When the initial gout flare resolves, then the treatment focus turns to trying to prevent gout recurrence, and this is done by lowering the urate level with urate-lowering therapies such as allopurinol or more recently febuxostat, which are xanthine oxidase inhibitors. Purines that come from the diet and from breakdown of nucleic acids needs to be metabolized by the body into uric acid for it to be excreted, and this process is mediated by the xanthine oxidase enzyme, which converts hypoxanthine into xanthine and then uric acid. Therefore, by inhibiting xanthine oxidase, you can get a reduction in the uric acid level, and therefore reduce the risk of gout recurrence. However, by starting a xanthine oxidase inhibitor, you can potentially reduce the concentration of serum urate quite rapidly, and this rapid reduction in the concentration can also lead to precipitation of the urate crystals and hence lead to a gout flare. And so generally, when initiating urate lowering therapy with the xanthine oxidase inhibitors, you need to also give gout flare prophylaxis with concurrent colchicine, and you continue to gradually up-titrate the xanthine oxidase inhibitor until the patient reaches their target serum urate level of less than 0.36 millimoles per liter, or in the case of tophaceous gout, less than 0.30 millimoles per liter. Because serum urate is being drawn into the joints and precipitating as crystals, the serum urate level is not necessarily elevated in patients who present with a gout flare. And so the utility of the serum urate level is more to determine what the patient's baseline urate level is and to help guide ongoing management with urate lowering therapy, rather than to actually aid diagnosis of the gout flare. Another important management point is to try and identify factors that can lead to an elevated urate level and hence contribute towards a gout flare. These include things like a high purine diet, particularly eating a lot of meat and seafood, or concurrently taking medications which are excreted by the organic anion transporter in the nephron, which is the transporter that secretes urate into the urine. These medications include the penicillin and cephalosporin antibiotics and the thiazide diuretics. And because they are also excreted through the organic anion transporter, there's less urate being excreted, and therefore the serum urate level may acutely rise, which leads to precipitation of urate crystals in the joint and hence a gout flare. Apart from also being a crystal arthropathy, pseudogout is clinically quite different from gout in that the affected joints more closely resembles that of osteoarthritis, and so really should be called pseudo-osteoarthritis. But anyways, pseudogout can be seen as chondrocalcinosis on X-ray, where there is calcification of the cartilage, or by detection in joint aspirate, although the presence of calcium pyrophosphate crystals in the joint aspirates of particularly elderly patients is relatively common, and it may not actually be the cause of the joint pain. Pseudogout is treated the same as acute gout, but without the need for urate lowering therapy in the long term. The other major etiologies that can cause arthralgia are that of the autoimmune diseases and autoinflammatory diseases, for which there are wide differential diagnoses with overlapping features and many different tests that can help clarify the diagnosis. We'll now go on to discuss the various specific autoimmune and autoinflammatory diseases and discuss the tests that can be used to investigate for them, before finishing with a practical approach to investigating arthralgia.